Hi everyone, myself Prabhakar, Associate Professor, Department of Pharmacology. Today we'll discuss about the anticoagulants. So before going into the anticoagulants, let us discuss about the general terms and things of anticoagulants. So anticoagulants are drugs that prevents the delay or clot formation by interfering with coagulation cascade, thereby inhibiting the fibrin formation. Anticoagulants play a crucial role in preventing the pathological thrombosis, which can lead to severe conditions like deep vein thrombosis, DVT, pulmonary embolism, stroke, myocardial infarctions. Uh, Unlike coagulants, these drugs do not dissolve existing clots, but prevent their formation and extensions. So they act by targeting different steps in the coagulation cascade by inhibiting the thrombin, blocking the factor 10A, and reducing the clotting factors synthesis. So these are the general things that we have to keep in mind while studying the anticoagulants. So let us move on to the classifications here. We have a set of systemic anticoagulants like heparins. Heparin, for example, heparin, enoxaparin. So these are known as low molecular weight heparins generally. The mechanism is to activation of antithrombin 3 to form inhibition of thrombin and 10A. The route of administration is generally intravenous or subcutaneous injections. Next, we have the vitamin K antagonist. Generally, they are warfarin as well as which is used to inhibit the synthesis of factors like 2, 7, 9, and 10. So generally, they are given orally, the warfarin. Next, we have the direct thrombin inhibitors. Uh, Generally, they act through directly to inhibit the thrombin 2A. Generally, they are given in the oral route. Next, we have the clotting 10A inhibitors. 10A inhibitors, they are rivaroxaban and apixaban. Directly, they inhibit the factor 10A, which is given orally. So, parental direct thrombin inhibitors are bile, so bivalirudin and agaptan. So next we have the mechanisms as direct thrombin inhibition given as IV. We have indirect 10A inhibitors, fondaparinux. So inhibit the 10A via antithrombin formation given orally. Okay. So these are all the systemic anticoagulants. Next we have in vitro anticoagulants like calcium chelators and oxalates. So calcium chelators are generally ADTA and sodium citrate, which binds to calcium and prevents the clotting. So calcium is considered to be uh, clotting factor. So next we have the blood storage and the lapis use as a usage. We have oxalates, potassium oxalates, and which will lead to the mechanisms through precipitate the calcium ions. So generally there is in the laboratory. So this is the mechanisms through which the anticoagulants work. As we discussed in our previous uh, coagulants. So here there are two pathways of clotting, intrinsic pathway as well as extrinsic pathway. So in the intrinsic pathway, the series of steps will be taking place, leading to the final step, the thrombin plus clot formation. So this is how they act. uh, First 12 will be converted to 12A. So 12A will assist to the 11 to 11A formation. So 11A will assist the conversion of 9 to 9A. So 9A will combine with 8A to form plasmin plus calcium complex. So this is known as factor 10 activation complex. This factor will activate the complex, leading to the formation of 10A. So this 10A will convert the 2 into 2A. So 2A will assist the 1 into 1A. So that is the fibrinogen to fibrin. So fibrin will assist the conversion of 13 to 13A. That's which leading to the cross linkage of fibrin. So here the drugs, set of drugs, we as we discussed in the classification, they will inhibit certain steps. So the major thing, the inhibition of 2A, that is thrombin. So these are the drugs which will inhibit the thrombin. You can see clearly here. Next we have the inhibition of 10A factors. and also the tissue factor pathway inhibitors, and also the low molecular weight heparins. So these drugs will inhibit these steps to prevent the clot. So next we have the general set of adverse drug reactions. Heparins, heparin will lead to the heavy bleeding and HIT, osteoporosis conditions, etc. Vitamin K antagonists will lead to bleeding and skin necrosis, and also they are teratogenic, generally leading to the malformation of the fetus. Direct thrombin inhibitors are leading to bleeding and dyspepsia. So here the bleeding is common in all the drugs because generally they are causing the coagulations. Then we have the parental diaphragm inhibitors will lead to bleeding. So next we have the teni inhibitors which will lead to the bleeding and injection site pain. So these are all the key considerations that we have to keep while giving anticoagulant therapy to a particular patient. So first risk is the bleeding risk. We have to monitor for the sign of bruising, hematuria, bleeding gums, black stools, etc. And also we need to monitor the dose. So warfarin requires INR monitoring. So DO is usually do not require. The drug interactions, especially the warfarin, will interact with several antibiotics, NSAIDs as well as antifungals. Food interactions like vitamin K rich foods reduce the warfarin effect. Next, we have the renal functions. So, for kidney failure patients and those who have the chronic kidney disorders, the dose adjustment is required, and then which will lead to the kidney impairment or and then we have the liver function malfunction, affects the clotting factor synthesis and the drug metabolism. And during pregnancy, as we discussed earlier, warfarin is teratogenic. Therefore, the heparin will be preferred for the pregnant women. So, adherence, strict compliance is required to avoid clotting or bleeding complications. And then antidote availability, vitamin K, uh, protamine sulfate. So these are all the set of antidotes that will be that should be used during the anticoagulant therapy. So next we have the age-related factors. Elderly patients with hypertension, ulcers, leading to the higher bleeding risk. So these are all the key considerations to while giving the anticoagulant therapy. So that's all. Thank you.